Good evening. This is Brian Davis. I'm very grateful to represent SAGES Resident and Fellow Training Committee, chaired by Mike Awad. We've got a very distinguished guest panel. SAGES Award winners speak on career development. I think it'll be very evident from talking about people's distinguished careers on this panel is that everyone has achieved incredible success looking at SAGES as a platform for mentorship, for growth, for leadership and development. This original idea, I want to thank Rebecca Peterson for bringing this to our committee in a way to recruit for the Junior Faculty Development Award, as well as to highlight the leadership that has come through SAGES. Through these, we have speakers starting with myself. I'm the program director at Texas Tech El Paso. Then we'll go on to Rebecca Peterson speaking about her career as a surgeon and what SAGES has done incredibly for a lot of us in this field, and about how she has a fundamental role in the SAGES Research and Development Committee, which chooses the Young Faculty Development Award that Dr. Talem has received and that Dr. Awad has received for very innovative programming. And Dr. Talem will talk about how she's really innovated in the field of public health research, and then followed by Eric Pauly, who has really revolutionized a lot of the ways we think about natural orifice transluminal surgery, finalized by Dr. Awad, who's been so critical in leading Resident Fellow Training Committee and in developing the SCORE platform, which now is almost universally used for residencies across the nation in preparation for the American Board of Surgery exam. What I'd like to do is talk individually about each person before we move on to these presentations. Dr. Peterson really has a very distinguished career, most notably starting out at my alma mater as a DeBakey Summer Scholar, and then progressing on through Oregon Health Sciences University to Duke, where she completed both residency and a thoracic oncology fellowship, and then worked with a great mentor at the University of Washington with Brent Oschlanger and Carlos Pellegrini, eventually staying to be faculty and associate program director with exceptional leadership in the Research and Development Committee and great publications on the long-term outcomes of periesophageal hernia repair, use of transoral fundoplication, and recent great talks on what it takes to be successful in academic surgery and how to raise children and pursue an academic surgical career. Followed by Dana Talem, who trained at Mount Sinai, then went on and did a great fellowship at Massachusetts General, including Columbia Masters in Public Health, focusing on health quality, safety, and outcomes research with significant grants of over $3 million with Justin Dimmock at the University of Michigan, focusing on outcomes of gastrointestinal and bariatric surgery. Dr. Talem's on editorial boards for Annals of Surgery, surgical for obesity and related disorders, surgical endoscopy and hernia, and also has provided a tremendous amount of leadership in increasing diversity and representation for women in SAGES in academic development and research, and has been to Washington as part of HRQ studies, also as part of National Quality Forums, and really is a leader in advocacy for implementing evidence-based medicine and surgery. Our next speaker, Eric Pauly, has done incredible innovation. I think my favorite, Eric, was your Hershey Hero Award. And looking at your CV, including over $1 million in industry support and 3 different SAGES Research Awards over the length of your career, and really creating incredible innovation and endoscopic innovation and achievement, especially with support of the fundamentals of endoscopic surgery curriculum and through simulation and development of new products, including several patents, and just really revolutionizing endoscopic surgery to include all the courses you've taught at the College of Surgeons, even as far away as teaching in India. To round out our speakers, Mike Awad is going to talk about his development of a career after completing an MD, PhD at Johns Hopkins and moving through his time at Washington University to develop the Washington University Institute for Surgical Education, having his own fellowship in that aspect, and really developing the whole online surgical education curriculum nationwide. So I think we've hit that time. I will tell everybody, SAGES is a great organization. As you can see, there's a tremendous diversity of leadership. This is from one of the Board of Governors meeting. The speakers here today, Dr. Tilem Peterson and Dr. Pauline Awad, are all members of the Board of Governors, and it really is great mentorship and leadership. Obviously, SAGES membership comes with discounts to the meeting, cutting-edge educational opportunities to teach and learn from some of the world's experts, access to colleagues that really create exceptional opportunity for growth in academics. And we want to really emphasize, too, there is a great component for educational leadership coming from residents who become candidate members at only $70 for initial registration, followed by a letter from your faculty to join. And it should be noted that we have representation members from residents on the Resident Fellow Training Committee and throughout the organization to affect how we deliver content most effectively for the members. It should also be noted many of these members have members-only research grants, including career development awards and leadership opportunities through committees that really shaped SAGES organization and their careers selectively through their specialties, really made a tremendous impact. So the vision of SAGES is reimagining surgical care for a healthier world. We'll see that through an incredible diversity of advocacy, all the way from career advocacy with Dr. Peterson through health outcomes research with Dr. Tilem, and national advocacy for educational innovation and national platforms with Dr. Awad and Dr. Pauly, obviously bringing incredible simulation and endoscopy. Our values include the inclusivity, supported and promoted by Dr. Tilem, innovation with Dr. Pauly, much of the surgical education by Dr. Awad and myself, and I think all of us support a very globalized community and have a lot of fun in the meantime. So, membership categories, again, we talk about the audience we're talking to today with residents and fellows. Really want to promote candidacy, promoting that to move forward onto active membership and application for these career grant awards. Please go to our website, and I'd like to encourage everyone to interact with the chat box. We'll be answering questions as the webinar progresses, and then I will selectively be able to activate a few participants to be a one-on-one live chat as indicated by some selected speakers such as Dr. Peterson and Dr. Tilem, who would appreciate interacting with any of you online that want to go live visual with our speakers. I'd like to invite Dr. Peterson to start with her first talk. Thank you.
Sorry, Dr. Davis, one moment. So thank you, Dr. Davis, for your kind introduction. And for all of you who've joined our webinar this evening, we're really excited about this theme. It's definitely not the traditional topic of a disease process, but we're hoping that you'll be inspired by our speakers today. They're all past career development and grant awardees early on in their career, and they're also folks whom I very much greatly admire. Just a moment. I have no disclosures relevant to this talk. So I plan to touch upon the following topics that I believe are essential to consider when developing your career as a surgeon, whether you ultimately decide on academic, community, or a hybrid practice. I think that the first and foremost principle is that you really must find your passion. What truly makes you excited to drive to work each day? If you're able to identify your passion early on, specifically in a supportive environment, I think that this alone is the first step to success. There will be an obvious theme of passion, as you later hear from our speakers today, which has helped define their careers early on. Once you find your passion, you must then find a clinical niche. For me personally, after finishing my MIS fellowship, I was hired on the next day at University of Washington. I was charged with getting a hernia center up and running. This provided an opportunity to really increase my skill set by attending numerous courses, developing a referral base through marketing, giving neighborhood clinic talks, grand rounds, local society talks. And in addition, spending time with my colleagues developing and optimizing perioperative protocols, teaching nurses, patients. And I think with the development of a program after identifying a clinical niche really gives the opportunity to enhance education, specifically for medical students and residents. And then that leads to opportunities for research development and quality improvement initiatives. I think the ability to encourage niche development and focus for junior faculty is really a sign of a great leader, in my opinion, whom for me was Dr. Brandt Oschlager. So the next principle, I think, is really seeking out your environment and choosing it very wisely. I think as you embark from your fellowship, or you embark into fellowship or your first job out of residency, it's really paramount to surround yourself with mentors and role models that you personally respect and ones that you want to emulate, and also realize the importance of work-life balance. Before taking that job, I think it's really important to get to know your institution's cultures. Are your colleagues collaborative? Do they have similar goals as you of providing first-rate care? Are they interested in program development? Are they dedicated to research and education if those are your goals? But bottom line, I think having similar goals is really important to get things going, because if you don't have buy-in from your partners, I think it's really hard to be successful. So regardless if you choose academia or community practice or a hybrid model, I think service is going to be your key centerstone of your career. So your first goal should really be to always provide excellent clinical care for your patients. I think this is all why we decided to go to medicine in the first place. And then service will extend beyond patient care and really extend into the community and then to your profession. So some examples of these activities include being on hospital and medical school committees, or becoming involved locally or in national organizations. So teaching is the next principle. So it comes in, teaching includes all levels of learners, from medical students, surgical residents, and fellows to multidisciplinary students, physician assistants, nursing and pharmacy students. And teaching can also include colleagues, for example, being a faculty of community courses or National Society endorsed courses. I think that the next level of teaching really involves development of curricula. Some examples of these would be development of milestones or simulation curriculum. And then, if you're interested in research, we all know it comes in various flavors, from experimental to clinical or epidemiological research, and that the topics widely vary from clinical outcomes, product development, surgical education, workplace environment, just to name a few. And as we all know, the majority of funding for research, it comes in various levels, more locally from your institution or your department, going on to national society grants, to the coveted government sponsored grants. So the institutional or the national society grants really can provide seed funding to assist in the process towards obtaining a more later on during your career, to a more competitive national or federally funded grant. So several of our speakers today, I think, will be touching upon their journey in obtaining funding really to support their research interests earlier and later on during their careers, but you've got to start somewhere. Dissemination of your research really is giving presentations locally, nationally, internationally, writing textbook chapters, or being an editor of a textbook or manually. And finally, publications in peer-reviewed journals. So, so what can SAGES do for you? We just heard from Dr. Davis of, many of the attributes, and for all of us on this webinar have gained a great deal from SAGES. But I think whether you join SAGES or another society, you really need a go-to society where you get involved early on in your training. And I can speak from personal experience that joining SAGES as a resident, which was a long time ago, has been a really rewarding experience over the years. And I think what I cherish most is the lifelong network of friends. And after knowing these colleagues for many, many years. They're really viewed as an extended family. SAGES specifically is an organization that has limitless opportunities to get involved at all levels. Speaking, getting involved as a resident. It's a society that is really known for its multimedia educational programs, resources. There's basic and advanced resident and member courses, research and career development guidance and opportunities. And you've heard about the fundamentals certification. Innovation, and most importantly, SAGES is inclusive, and I think it's really fun, which I think is really important. Whether you choose to, again, join SAGES or another surgery, get involved on a deeper level. So I think it's really, you get more out of a society and where you get involved and you really attend that specific meeting annually, as opposed to spreading yourself thin and trying to attend multiple national societies, specifically in your junior years. So again, just to emphasize the educational content, there's a master's program of 8 common surgery disciplines, in addition to endoscopy, robotics, and leadership and professional development pathway. This is in development, but is going to be a really go-to resource for all. It has numerous up-to-date manuals, a plethora of videos, which I think is really great for residents to view prior to going into their cases, Safe Coley program, a large variety of recorded live and non-live lectures from our recent annual virtual meeting, in addition to pre-recorded webinars like this one. And then I think also there's a variety of resident courses and that have received really great positive feedback and are really popular. In addition to more, as you get further along in your training, there's more longitudinal adopt courses currently in hernia, foregut, and colorectal surgery. So in regards to research support and opportunities, each year there's a general research and specialized research grant opportunity. So this year it's going, for the specialized grant, it's going to be robotic focused. We funded 3 COVID grants in the spring. The total budget for the general SAGES grant is $30,000, which is a significant amount of money. And then it's $50,000 for the robotic focus grants. So these applications will become due later fall. And then we really encourage you to apply for grants if you're interested. We have a lot of resident applicants, and if you do so, definitely take advantage of all of the resources that are available. For instance, you can watch a YouTube video created by the research committee on how to write the perfect grant. And then there's examples, which I think are very helpful, where you can view these grants that have been awarded in the past. And one of these is Dr. Paule's grant, who's speaking tonight. I think we tend to forget all the resources available simply on the website. And so if you're writing a grant, definitely look at the criteria that goes into scoring your grant. I think this is very helpful. If you look at all the individual components, you definitely don't want to miss putting in a power sample calculation or a timeline. Again, looking at all the different components of the grant and knowing that scores are associated with this grant, which helps us rank the grants and spend a lot of time reviewing these. And then following, instructions. So the budget is really important as well. Don't ask for salary support for the PI, which is a common pitfall. And also, just because the grant is up to $30,000 or $50,000, it doesn't mean that you need to apply for that amount. Be realistic. You can always apply for a lower amount. That's a really important consideration when choosing which grants to fund. And then seek out advice from your colleagues and mentors on which grant opportunities they recommend if as a resident you want to endeavor in getting a grant and being successful. There's many workshops and webinars, and we're working on arranging a webinar in the future on grantsmanship. And when you get involved in these webinars or seminars, bring your grant rough draft and make it a work in progress to take full advantage of that opportunity. And if you don't get funded, just the main advice I have is reapply, reapply, reapply. And when you reapply, take in consideration the consensus feedback that you got from the committee, and write a cover letter saying, we implemented these changes that were recommended, and resubmit. That goes a long way. So you're going to hear from our past career development awardees. So this is a different opportunity. It's really not a research grant. It's a award that's funded by the foundation that supports someone in training within 5 years, or someone that currently is training. So it's applicable for residents and fellows. We've awarded both in the past. The total amount is $60,000, and it's ultimately to provide protected time equivalent to 6 months without clinical obligations, and really to develop critical skills to advance one's career. So the awardees you will hear from, as you've heard, is Drs. Tellem and Awad. They've used the funding for various professional development activities, such as traveling, training fellowships, masters in public health, special clinical projects. And the key is that this award provides an opportunity to the applicant that would not otherwise be available without the award. And then, as we discussed, so diving deeper when you get involved with these national societies, if you are interested in a committee, I urge you to look at the lists of the many committees that we have, and really choose one that you think fits you. You go online and fill out a volunteer form. And before doing so, you can view YouTube videos of the chairs and the overall goals of the committees. And after you decide which ones you're interested in, spend the time to write a good personal statement section why you think this committee is a good fit for you. And then this is something, I'd like to show you. It's at the leadership of Dr. Tellem. The SAGES CV has been developed by the committee she chaired, formerly known as We Are SAGES, which is now the Leadership and Professional Development Committee. And so I'm using a PGY3, Dr. Garfunkel's CV. He's a committee member on the research committee. He's heavily involved in multiple initiatives on our committee, and has taken full advantage of what SAGES has to offer. The SAGES CV has a member statement. It looks at your committee history. It's auto-populated. It talks about faculty history, so if you've given a talk or been involved in a course. And so building this early, abstract reviewers for annual meeting, and then if you're reviewing any manuscripts for surgical endoscopy, and then it looks at meeting attendance. And so this is a nice tracking method for your individual activities that can be used by you and leadership. But I encourage you to get involved again. It gives you the various options of everything that you can take advantage of in your training years. So finally, to kind of provide you with a checklist, which again is relevant to any national society, join a society, pick one. I think SAGES is great for regardless of what discipline you plan to go in. Partly because I think you can dive deep when you're a resident and take full advantage. Again, knowing the multimedia educational content exists, taking advantage of all the videos before you walk into your cases with your faculty members. Attend webinars. So the next webinar, like this one, is the famous ABSITE review, which will be chaired by Dr. Michael Awad, one of our speakers today. That's scheduled for December 15th, so it's pretty timely before the January ABSITE. And then attend annual meetings and bring your family so they get involved in SAGES early on, and it makes it easy to have that longevity over your career if you choose this as your go-to society. A request to join a committee, research them if you're interested, fill out the form, spend some time on the personal statement, and then apply for a research grant. Those that are interested in research, I think this is a lot of money. We have a lot of residents applying, and residents get awarded. The Career Development Award is also very applicable at your stage. We have residents that apply for both. So I highly encourage you to think about that. And then the virtual meeting content that was recently done, very high quality and is available until spring. And then when available, the RAFT sponsored resident courses are really popular, specifically the robotic one, rave reviews, fill up quickly, and most importantly, have fun. So to end, I think that, really deciding your own path and what works best for you in regards to your career and timeline. There's definitely no right way. I'm always trying to find balance. It's definitely dynamic for me. Keep active. I think it's really important to optimize your mental and physical health by keeping active. Be flexible, have a sense of humor. It's a long road, a long, fun road. And I think it's really important to realize what we have in our profession is we develop really deep and lifelong friendships along the way. So thank you.
So Dr. Peterson, I'd like to bring up for a moment, you really have exceptional opportunities for leadership all across the House of Surgery. What I'd like to say, as a program director, it doesn't matter whether you're interested in acute care surgery, trauma, pediatric surgery, surgical oncology, colorectal surgery, we have opportunities for everybody. I mean, and I think we're one of the best societies for integrating residents at all levels. And I really want to compliment you for how you gave highlight to the residents participating in SAGES at this moment.
Yeah, I agree. I think this is a society that really gives you so many opportunities. And, the surgical oncology, destined residents or HPB, there's multitude of committees, and we do have residents on our committee, and they're very active participants, and really gain a lot from being involved. If you're going to be a member of a society, dive deep.
Really get the mentorship. I'd like to introduce Dr. Maria Ahmad, who's one of my residents, who'd like to ask you a few questions about what you've been through with SAGES. Dr. Ahmad is interested in doing bariatric surgery in the long run. Dr. Ahmad, thank you for joining us.
Thank you, sir. Hi, Dr. Peterson, Maria. It's nice to meet everyone. Yeah, I guess I'm a PGY too, so I'm relatively early in my career right now. It's always nice to have women in surgery who, you can kind of look up to. I guess I got interested in foregut rather recently. I mean, I would say about a year ago. I used to think that hernias were not exciting at all, or, minimally invasive surgery was not my forte. Until I guess I realized that I enjoyed doing it. What is your advice for me right now? I'm just beginning my PGY 2 year. I am interested in clinical medicine, as academic medicine per se. In addition to, just getting to go through some level of, I'm interested in both academic medicine as well as practicing, obviously, and operating a lot, because there's only so much research I would like to do. But what advice would you give me right now?
So one question, do you have any protected time during your residency? Are you spending any time in research years or?
So we don't have protected time. However, I am involved in research. I did have a Southwest Surgical abstract presentation last year. Obviously, it's going to be a virtual thing now at this point. And there, I am going to present in the Clinical Congress right now virtually as well. So we have a couple of projects going. They're mostly HPB right now. I would obviously also want to be involved in some bariatrics at this point. We just don't have exposure to bariatrics until our 4th year.
No, that's very helpful. Congratulations on your already success with your endeavors. Very nice to meet you. I think getting involved in SAGES and looking at the committee lists and really looking at opportunities, the reason why I asked if you were going to, if you were having dedicated research time, I would definitely push you towards, getting applying for, a research grant or doing the Career Development Award a little later on as you mature. But I think if you get involved early on and you become more focused in your clinical interests, you really can tailor that to some committees and go to the annual meetings. You're in a great, you've got a great mentor right now. Networking is always important. And that's where I started. I went to a career development resident course in Florida that was sponsored by the research committee at the time. And I've been involved with the committee since then on various levels. So I think getting involved early is really important. I'm pushing Dr. Davis to let you go to the meetings annually and not being on call. So
it'll happen. It's all about doing
Yeah.
research.
I honestly was not very, I was not very familiar with SAGES. I have heard Dr. Davis talk about it multiple times, but I guess just getting through intern year itself for that point of time and whatever little research I could do was one of the things that I was focusing on at that point. But I guess as second year, you do have a little bit more time on certain rotations. And yeah, absolutely. I'm going to look into it now.
Yeah. I think you realize what's available when you actually sit down on the site and look at the educational content. Because I say the same thing, to our residents. There's so many recorded lectures, and if you're doing a laparoscopic inguinal hernia, you can look at the 10 Commandment lecture. There's all the videos. There's the pitfalls. There's the complications. And I think that I think that sometimes the residents don't realize how much value there is on that with the educational content. So I think starting there is step one. I'm happy to have others chime in on additional advice for Maria.
Thank you so much, ma'am. Absolute pleasure talking to you.
All right, I think it's good that we start with Dr. Telem next.
Great. Thank you so much. Thanks, Dr. Peterson. I always learn when I listen to your talk. So I think I was mesmerized just realizing all the things that I forgot that we have. And I'm so glad that we remember. So I was charged today kind of to talk about the Career Development Award and specifically some involvement with our bile duct injury prevention efforts and how that all kind of plays together. I'll say I'm not accustomed to giving talks about myself or my career and how I made decisions. So I actually was really grateful for this talk because it made me a little bit introspective and made me realize again how much I appreciate SAGES and even more so than the organization, but the people in the organization, of whom many on this call were co-fellows with me or people who I've met and enjoy talking to, as well as having a beer or glass of wine with at any different meeting we went. And it was really fun from that perspective. I will say these are my disclosures. None of them are relevant to the talk per se, but they're all relevant to the talk, which none of this would really be possible, I think, without having had this CDA as a launching point. I also want to make my disclaimer that I do love this organization and that I do think that, a lot of that was responsible for my success and any continued success that I have. I'll make one more disclaimer that at any given time, 2 small children could run in here and totally blow up this Zoom call. So I apologize in advance if that happens. I have no control in this house anymore. We are all virtual, and I will apologize in advance for that. So I think the question is when you're thinking about applying for any type of award, whether it's a career development award, a grant, a prize, or whatever it is, you really have to reach down and figure out your why and why are you doing this? I think a lot of times, and myself included, tend to be very task oriented. If I get this, then I'm going to get this. And if I do this, then this is going to happen to me. But I think sometimes having that little bit of introspection to figure out, well, what is it that you're actually trying to achieve? What is that end goal that you want to do really helps you along the way. And I'll tell you that I really didn't figure that out until my early faculty career, which is where I'm going to spend a little bit of time talking about most. I started out in residency at Mount Sinai in New York City. It was a fantastic residency, at which time I took 1 year out for academic development. During that year, I sort of fell in love with what we called outcomes research. I'm not sure health services had been coined, or if it had been coined, I just didn't know. For whatever reason, I thought we were the only people doing this, although I know that's not true at all. And I really enjoyed trying to understand the intersection between what we did and what happened to patients and how could we do things better. So a lot of my clinical interest is ultimately what fueled my academic interest, which is if patients aren't doing well or they're not having ideal outcomes, how can we decide what we can do differently to change that for them? That love and passion kind of went into a decision to go to minimally invasive surgery, which I chose namely because of the innovation in the field. I thought that the field was incredible, fast-paced, and really thoughtful about how can we do things better, whether it's through smaller incisions, whether it's through endoscopic procedures, but always looking to push things forward and improve patient outcomes, which really married and sort of dovetailed with my academic interests. I did my fellowship at Mass General with David Ratner, and I also went there actually to work with Matt Hutter, who was really just at the forefront of outcomes surgery. I had a really wonderful year, and during that year, it led me to meet Dr. Pryor, who many of you know is our past president of SAGES. Dr. Pryor at that time had just left Duke and started at Stony Brook to build a program. And I was fortunate to have the opportunity to be recruited and go there to work with her in terms of, you know, A, developing our bariatric program, but B, really kind of learning all of the clinical delivery skills and having her as a mentor, which was absolutely a tremendous experience. She is a phenomenal sponsor. She's a phenomenal mentor and somebody who really helped my career tremendously. And from there, I went over to the University of Michigan, which is where I am right now. So I'm going to spend a little bit of time, I think, talking and focusing on this early career and how it came about that I went for this career development award and how that fit in sort of to my master plan and how actually I ended up at Michigan. So when I left fellowship, I was really, really eager to continue doing outcomes research. I really wanted to build this as part of my program. I knew that this was something I was passionate about and something that I thought I would really make a career out of. When I showed up at Stony Brook, however, it was a little bit challenging because there wasn't really an infrastructure to do any type of research, nor was there any data. As I told you, I was coming over to a new program. Rory had been there, I think, about 10 months before I showed up at the door. And so we didn't really have any robust data sets. This was sort of before the time even that ASMBS was releasing some of the, you know, the PUF files so that you can do research. So then the question is how do you get data when you're in a poorly resourced area and you need to do data and you want to do outcomes research? And this is where I think a lot of kind of being an MIS surgeon helps, right? We're used to out of the box thinking, we're used to being innovative, we're used to trying to think, how can we do things differently? What can we do to get around this box? And so one of the things I noticed was that there was a New York State database or a data set called Sparks. And I had researched this because I needed to figure out how to get a large data set. However, I still didn't have any money and I didn't have any statisticians and didn't have anything like that. So what do? You call the New York Department of Health, because why not? All they can say is no. Everybody says no to us all the time. It's just another no that we can do it. Well, thankfully, I found these lovely two women MPHs, and they decided that they would take a chance on this first year attending, and they would partner with me, and they would help me with statistical support. And from there, we really grew and flourished. We made arguments, got resources, had a statistician, and started our outcomes-based research, which was like a cross-disciplinary enterprise and ended up having 20 people. And we were cranking. We were probably publishing 15 to 20 papers a year. But something felt like it was missing. And even though by all objective metrics, like paper count and things of that nature, it seemed to be doing well, at the end of the day, I really started questioning really if I had the skill set at this time, one, to lead a collaborative like this, and two, to really have a deep knowledge of methodology and questions and writing and framing questions to really do the practice changing research that I wanted to do, as well as get funding. And to me, funding was just kind of like this holy grail. And again, it was a task oriented thing rather than actually something that was being used to support my research, which is a framework that I switched a little bit later in life. And then the final question that I had was that I really have the skill set to mentor others. Like if I was trying to figure this out on my own, did I really have the skill set to help somebody else develop it as I was trying to develop myself? And so that led me to really think about, what do I need? What do I need to get to that next step? And one of the things I thought was that maybe that getting a master's in public health is something that would really help me do this and help give me the skill set that I need. And I make this as a decision node right now because it's not infrequent that I'll have medical students or residents come up to me and be like, do I have to get a second degree? Do I have to get an MPH? Do I have to get an, MBA? And I guess MHA is all the rage right now. And people ask, do they have to do it? And it's the same thing. I'll tell them, like, you don't need a secondary degree just to have a secondary degree. A secondary degree is really helpful if you know exactly how you want to apply it, what skill set you want to develop from it, and the things that you need to take from there. And so I went in there thinking that this was something that was going to give me a stronger foundation and methodology. But what I found was that it actually gave me a stronger foundation in healthcare delivery and innovation, which turned out to be really important subsequently, as well as in clinical operations. And most importantly, just like SAGES, it helped me develop a really robust and diverse network ranging from business folks to other physicians and architects, within the field, that really helped broaden my scope and broaden the lens that I saw the world in. And so when I think about how did this help me, I think about it first from the 30,000 foot view, and apologies for putting an airplane wing on here. I miss traveling so much. It was nice to kind of pretend I was looking out of a window for 1 second and maybe hopefully flying to SAGES 2021 in Las Vegas, God willing, if we're all through COVID now. But I think that this really helped me on my career trajectory because it really helped me mature. It taught me sort of what are those building blocks that I needed to attain the funding. But most importantly, it taught me the importance of mentorship, because right at this time, as I was thinking about how am I going to do this next step, I had made the decision to leave Stony Brook, though it was hard because it's a really wonderful job, to go to University of Michigan, specifically because I realized that there was a gap, that if I did want to attain federal funding and if there was something that I really wanted to do, that I wasn't going to be able to achieve that without proper mentorship. And it's also something that really helped me for my institutional leadership roles. I hold a vice chair in quality and patient safety. Much of that clinical operations and delivery was directly resultant from that master's in public health, as well as I'm currently the section chief interim, and I'm responsible for 45 surgeons and 100 people sort of in our Department of Surgery, and thinking about all of those clinical delivery goals as we kind of get through COVID. And this MPH, which was kind of run as an MPH, but almost as an executive management program, really gave me a great skill set in weird things like accounting that we don't really think about that helps with clinical operations and delivery. So on the one hand, it was great because I went in there thinking I was going to learn more statistics. On the other hand, I came out with like a really good fund of knowledge about how to look at a spreadsheet or a profit and loss sheet and be able to make good clinical decisions accordingly. But I was asked here to talk about bile duct injuries, so I will talk about bile duct injuries specifically. So as this was going on, I had an interest in bile duct injury epidemiology and outcomes. I think that bile duct injury is sort of one of the worst complications that we can do. And I have this kind of affinity for the underdog, and particularly underdog conditions like hernias and gallbladders that typically don't get the same respect as pancreas cancers, but at the same time impact more people, and when they go really wrong, because people expect to have a good outcome, not to have 30 surgeries later and end up, with diminished quality of life and decreased quantity of life. And so started looking at some of the outcomes following bile duct injury, published a little bit on this surgical endoscopy, and it caught the eye of Mike Brunt, who you can see in the upper corner of this talk. And we just had this like random conversation during the quality committee meeting, and I joined that committee, I think as a resident or first year faculty, again to dovetail with my outcomes interest. And we started talking a little bit, and he told me about this thing called the Safe Cholecystectomy Task Force, and I don't think I was originally invited, but that's okay because I ended up getting on the task force anyway. And we started collaborating, and you can see down here, this is sort of the first picture before anything kind of came to fruition. I think I was like 7 months pregnant into this picture, and we flew down to WashU, and we sat down and we just had a conversation about where are we, where does the field need to go. And from this, we also started talking about some collaborations and ended up publishing a paper together, again, looking at bile duct injury and morbidity following this operation. And this is something that really, really blossomed over time. And I had the honor and privilege to be part of this committee when we put out really great content The Safe Cholecystectomy didactic modules, I know, is something that happened under Mike Brunt's leadership and his presidency, and something we're all extraordinarily proud of, as well as the State of Art Consensus Conference that was now 2 years ago, which came out with recommendations and prevention strategies for implementation. And here it was really great because I could really help kind of flex some of the muscles that I learned from the Career Development Award and along my time through my faculty, and help write an NIH grant. And we did end up getting some funding to be able to carry on this conference. It was really nice to bring that to fruition. And so from this opportunity, and this is kind of node 2 or piece of advice 2, is when people give you opportunities and you do well, and sometimes doing well just means showing up and do work. When you say that the work's going to be done, it ends up bringing more opportunities, and then from those opportunities you grow. So from this, I was able to then ended up being chair of what was called We Are SAGES, and now as the Leadership Professional Development Committee, I was able to be appointed to the board of directors for SAGES. And this spring will be the 2021 program chair, and I hope that we will be in Vegas. So I really think that the most important thing anybody can do is just try and show up. You know, Dr. Peterson talked about this, is keep trying. We call it kind of shots on goal. The more you try and the more you show up, the more likely that you are going to be successful moving forward. And so I think to summarize this, you know, the CDA gave me funding, but more importantly, it gave me a platform and it gave me opportunities. It gave me opportunities within the organization through random conversations, through developing a skill set, but it also gave me a ton of opportunity, both internally for leadership and externally. So the 2 thoughts that I'll leave people with, whether you're thinking about applying for this award or another award or just to MIS in general, is 1 is intentionality. Always kind of go from your why. Why are you doing this? How is this going to help you? And I think that'll actually help frame writing the award and make it more powerful and impactful. And second, think a little bit out of the box. And this is just to reiterate one of the points Dr. Peterson made, which is there are very few awards that aren't meant to fund grants. And so if you have an opportunity to apply for an award that can fund travel, that can fund a degree, that can fund something different that's going to end up being a huge adjunct and have a huge impact on your career, go for it. And I think that's one of the things that are really instrumental with this award, is that it's really one of the few out there where you can kind of do anything you want with it. And so if this is something that you're interested in, think big, think innovative, think out of the box, and give it a shot. So I want to say thank you. Here's my contact. You can email me anytime. I'm very available, and I'm happy to answer any questions that people may have.
Hey, Brian, you're on mute if you're talking.
Thanks, Eric. I was asking a question of Dana real fast. You mentioned that you snuck onto the Safe Chole task force, and I felt like I also snuck on as well. Can you talk a little bit for the residents and fellows? How do you really get involved with committees and make these projects happen? Because obviously a lot of colliding interests, you know, get involved. I do a lot of ERCP and bile duct work, and I think there's a lot of synergy in SAGES where people don't realize there's really a lot of openness toward task forces, especially. And then with, you know, special contacts and the right mentors, I think a lot of things open with committees as well.
Yeah, I think there's honestly no secret sauce. It's showing up to the meeting, raising your hand if somebody asks you to do something, and doing it well and on time. If you do that, that's the key to 99% of success on a committee and life success in general, because there's nothing more frustrating to a committee chair or co-chair than, one, when nobody volunteers to do work that needs to be done, or sometimes what's even worse is when people volunteer but then never kind of follow through and you're chasing people down. So I would say 99% of life success is just showing up and doing what you're supposed to do, and that people will know that, and people will talk about you. You know, if you're on a committee for a while, at the end of every year you get this survey and it asks who did a really good job this year on your committee, who would you recommend for further leadership within the organization. And when you've really kind of stepped up and into that position and embraced it, then once you get on that list, it just opens up a whole slew of opportunities for anybody involved.
Great. I think we'll move on to Dr. Polly, I can see him anxiously waiting.
All right, you guys should, you guys have a screen there?
You do.
Awesome. Well, for starters, thank you guys for inviting me to talk tonight. For the residents and fellows watching, I mean, honestly, it's exciting to watch other people talk, but it's also kind of intimidating to realize that, like, in a talk about how to be successful, you're completely outclassed, right? And my talk is maybe a little bit different. I'm going to spend some time talking about SAGES grant awards, including some of the ones that I've had, and how that involvement in the SAGES grant process led to some other cool things in my career. I am, do I have a disclosure slide? I do have a disclosure slide here. None of the, these will have no bearing on the things I'm going to talk about tonight. So a little bit about me. I started med school thinking that I was going to go into internal medicine. And then I found surgery. Basically, I fell in love with surgery in an anatomy lab. And then I started residency thinking that I was going to be a private practice vascular surgeon. What I loved about vascular surgery was wires and tubes and catheters. What I disliked about vascular surgery was vascular surgery. In somewhere through the middle of my residency, I realized that I liked doing endoscopy. And I also realized that research was going to be part of my career. And I'll explain to you how that happened. I was basically told that I, because of the number of residents that we had in the program, needed to go out and do a year of research. And I was okay with that because I realized that if I was going to do a fellowship, I probably needed some additional research. And then about 3, maybe 4 months into my first year, I was in love with doing research. And I realized that I needed to do another year, and I went back to the program director and said, "Hey, I got to do another year." And he said, "Yeah, don't worry. We already had you penciled out for 2 years because the numbers didn't work. So it's good that you figured this out, you know, kind of on your own." So going from a guy who thought he was going to be an internal medicine person, you know, as Dana said, it's kind of weird to talk about yourself, but currently I am a professor of surgery at Penn State. About half of my practice is complex abdominal wall reconstruction, and the other half is flexible endoscopy procedures. I just became our division chief, and I have, I started with 5 faculty. One started last month, just this month, September 1st, and I got one starting on October 1st as well. So we got 2 new faculty and 4 APPs and 2 lab residents and 1 fellow. I'm currently the chair of the SAGES Flexible Endoscopy Committee, and I've been the chair for maybe, 4 years now or so. And as mentioned earlier, I'm also one of the SAGES board members. I also have the privilege of being a Fellowship Council board member. And in my academic career, since I started doing stuff in around 2007 or so, I've got the stuff you see here, some papers, some book chapters. I've edited a few books. I particularly, as Dana said, miss travel, and I used to travel a lot. And I don't have a lot of grant money, but definitely more than other people, but not as much as some of the folks who are going to talk to me. So, how did I get from point A, thinking I was going to maybe be a private practice person, to point B, where I'm doing all the stuff that you just saw? And I'll be perfectly honest with you, I really did not have a plan. I think the biggest thing that I did was try to be true to myself in terms of the things that I enjoyed and wanted to make part of my career. And obviously I've learned a lot along the way. And I think what you'll see in the rest of this talk here is the points in which SAGES, kind of played a big role in that. And I'm going to basically tell you this in sort of 3 stories. So in 2006, when I first went out to the lab, I was in a minimally invasive surgery lab with the folks, I work at the same place that I did my training. So the folks who are my partners were doing my fellowship with me. And we started doing a lot of natural orifice surgery projects with our GI folks. And so for those of you who aren't familiar, natural orifice surgery is this idea that you can take an endoscope and make a hole in a perfectly good stomach and maybe take out the gallbladder or take out an appendix or do other stuff. And first off, this was automatically exciting because it was new and it was different. I was working with our GI colleagues, and there were many days where our surgeons weren't available. And so not only was I learning how to do flexible endoscopy, but I was teaching our GI folks about some of the things you've heard about, like, principles of critical view of safety and safe cholecystectomy, albeit in pigs. We developed our very first project was this idea for this thing called the self-approximating transluminal access technique, or STAT. And this was the idea that you can take an endoscope and tunnel across a GI tract lumen. We were doing it in the stomach. And you could actually then get out into the abdominal cavity. And when you were done, you had this kind of offset mucosal flap that prevented things from leaking. And this might look familiar to some of you as one of the basic principles of how to do a per-oral endoscopic myotomy and how we do a lot of other tunneling mucosal-based procedures nowadays. And so we wrote this up and we did a couple papers. And we were desperately, like many other groups at the time, trying to get funding. And the people who I were working with, who were faculty members, were writing grants that just weren't getting funded. And lo and behold, this option came along for a SAGES resident grant. And so I wrote it. And because it was a resident grant, I got to be the PI on it. And this was one of the first grants I'd ever written. I actually still have it, as witnessed by the fact that I have the stamp here in the original reply. It's not the best grant. I've reread it a couple times. I could have done some things a lot better. But it got funded, and it got funded because SAGES is willing to invest in junior people and invest in their career, and that's entirely what these grants are designed for. Dana, you may also note that the meeting was in Las Vegas that year as well, 2007, so there you go. This grant came to me, I said, as the PI, and so we did the project, and what we wound up doing was something like this, where we would start a tunnel in the back of the stomach and we would make a tunnel all the way around the greater curve. And when we came out, the endoscope was basically pointing directly at the gallbladder, which means that instead of having to retroflex to take it out, you were prograde with it. And we thought this was really cool. And so we published this, and I thought that was maybe, the end of the project. And then I got a Post-it note on my desk in my second year in the lab that said, someone named Jeff Ponsky called you and wants to talk to you. Please call. And then there was a telephone number. And for those of you who don't know, Jeff Ponsky is a former SAGES president, a former ASGE president, a former board member of the American Board of Surgery. He's an all-around amazing individual. He's the namesake of the Ponsky peg tube as well. Dr. Ponsky called and he said, hey, I was reading this paper. I think it's really great work. And I would like to use one of the pictures for this course that we're about to do. Could I have your permission to use it? And I said, sure. And then I realized that if he's already seen the picture, it's been published in Surgical Endoscopy and it's a black and white photo. And I said, hey, those are black and white. If you want the color picture, just send me an email and I'll give me your email address and I'll send it to you. And he said, absolutely. So I sent him the color pictures. And now I have I've got a cell phone number because he called me on a cell, and I've got his email address. So I've got the ear of a former SAGES president. They put the course on again a couple months later, and I decided that I was going to go. And so I called him up and I said, hey, I just want to let you know I'm coming to the course and I would love to introduce myself and say hello. And he said, of course. So I met Dr. Ponsky that day, and I also met this guy. This is Dr. Jeff Marks, a recent SAGES president, and also a flexible endoscopist, and Jeff Ponsky's partner. And it was that day that I decided that I was going to go work with these guys for my fellowship. And so from that point on, I was pretty much set on going to Case Western to work with Ponsky and Marks to be an endoscopist. I did a lot of research when I came back, and I did a few more projects before I finished my academic time at Penn State. But I got to work with Jeff Ponsky and Jeff Marks, and then a guy named Mike Rosen, who is a hernia surgeon you guys may have heard of, and a guy named Yuri Novitsky, and a guy named Ray Anders. And again, this is kind of dumb luck, but it all ultimately started with that SAGES grant that I, got a foot in the door with arguably 5 of the nicest, 5 of the most well-known surgeons in the country at the time, all of whom are very good mentors, and all of whom took it upon themselves to kind of look after me as my career continued to develop. So when I was there in Cleveland, I remained involved with SAGES. So as Dr. Davis noted, I have a couple other SAGES grants. So Dr. Marks was kind enough to put me on one of his grants as a co-investigator. He was also kind enough to nominate me for the SAGES Flexible Endoscopy Committee and for the Fundamentals of Endoscopic Surgery Committee that he ran. And, you know, Dana hit the nail right on the head, which is that when someone gives you an opportunity like this and you show up and you raise your hand and you say, yes, I will be involved in that and I will help out, and then you do the things that you say you're going to do, a lot of good stuff can come from that. And so, you know, by showing up and raising my hand and saying, yeah, I can get you endoscopic images for these things that are the didactic content of FES, no problem. And then just kind of went home and did it and brought it back in a timely fashion. Suddenly people were taking notice. And mostly because of my work on the Flex Endo committee, I was within a couple of years promoted to the co-chair with a wonderful guy named Ted Truss. Ted, you know, took me under his wing, gave me a ton of responsibility, but then unfortunately had a lot of things happen that called him away. And I got, you know, what we affectionately call as a field promotion, where even though Ted was still the official committee chair, I was kind of spearheading things. And then ultimately that led to me being promoted to the chair of the committee. And, you know, those opportunities, you know, I think show a lot about SAGES. Number one, we're here to talk about grants and how to get them. And obviously the fact that you guys are all junior in your careers and we have grants specific for people in your, you know, state of affairs is exactly the point, because they allow you to do some good work, to get noticed, to get on a committee, to again, continue to, you know, show that you are willing to be an active member of the society, and then kind of move your way up through the ranks. And if you had told me when I first started my academic career that that all of this would come out of, you know, my time in the lab, I would have said, that's ridiculous. This is about kind of following some of those, you know, lesser beaten paths and looking at good opportunities. The second story I'm going to tell you is another one about opportunities. And every once in a while, I ask a resident if they're interested in doing a project with me, or I have an idea for something and we kind of talk about it. And somebody says, yeah, I'm not really interested. I'm not sure it's going to lead to anything. And I understand that. But I've also seen the other side of it. And that's kind of what the story about the liver fist is about. So sometime in my chief year, our surgical oncology team was doing this. They were putting their hand like this when we were looking at CAT scans to figure out the segments of the liver. And you can also kind of do this, and you can name the segments and talk about liver resections. And this is honestly just a very simple kind of mnemonic to memorize how the liver looks. And I said to them, I go like, where's that from? Like, that's not in any book. Like, honestly, more people should know about this. And they said, I don't know. I mean, we learned it in training. So we called the guys up who trained them and they said, yeah, I don't know. I mean, we sort of made it up, but we don't think it's ever been published. And I said, like, I'm looking for a really straightforward project my chief year. Why don't I write this up? And so we did. And it was published, and it still pops up on Twitter every once in a while. It's kind of a fun thing. But that led to this. I got a call the year that this was published, which was like 2013, 2014, by a guy who was an editor at the Journal of Clinical Anatomy. And this is back before spam emails came and the journals were fake. This guy said, hey, I saw this thing you did about, you know, liver anatomy and how to make your fist into it, and I thought it was really clever. And I would love if you would write a clinical review of anatomy, all the way from like cellular level stuff, all the way up to like hepatectomies and things that you describe in that paper. And I thought about it for a little bit, and I realized that like I just finished a fellowship in minimally invasive surgery and flexible endoscopy, and I'm not a liver surgeon. But at the same time, I'm a first year attending, and I don't really have a whole lot of projects right now. I literally just started. And this guy, Ryan Yuza here, who's listed as my brand new lab resident, and he's chomping at the bit to do stuff. And I said, Ryan, like, look, I got this offer. If you want to do it, then like we can do it. But realize that like neither you nor I are liver surgeons, and this might not work out that well. And he said, no, like let's totally do it. So he did it. And honestly, to Ryan's credit, this is a fantastic paper. It's a great review of liver anatomy. I had very little to do with it. He gets all the credit, except that I got some additional credit, which is that this guy who was the editor at this journal several years later had moved to Seattle, had taken a different job, and he became one of the editors at Gray's Anatomy. And he sent me an email and he said, hey, like 6 years ago, you wrote this liver review and I really liked it, and it was based off of this other paper. Would you be willing to write chapter 60 in Gray's Anatomy I looked you up and it turns out that you're now a hernia surgeon. You want to write the abdominal wall anatomy chapter for Gray's Anatomy. And I said, yeah, heck yeah, I do. So, this all started from a really simple idea of this liver fist, which probably could have gone nowhere if I had decided to not write it up. And if I hadn't taken that next kind of step and said, yeah, I'll write a paper that maybe I'm not the best person to write, but because I'm being offered the opportunity and I've got a lab resident I got to look out for, that I'm going to do it, to all of a sudden, having a chapter in a pretty cool textbook. So small things can in fact lead to bigger things, even sometimes in very unexpected ways. The final story I'm going to tell you is about my most cited paper, which is called Diminished Paternity and Gonadal Function with Increasing Obesity in Men. I still get asked to review papers about obesity and infertility for the journal Fertility and Sterility. People call me and ask me for this data set. I don't know who these people are, but man, there are people out there who really love male infertility papers. This paper has several hundred citations, but the coolest part about this was I did this actually as a medical student. And I actually did it primarily because I needed some money and I did a research project for the summer that basically paid me to stay. But my wife was also working, well, she wasn't my wife at the time. She was just a girl in medical school class, but was also working with the same researcher at the exact same time. And so we basically met and spent a lot of our first, moments together at these research meetings. And, that led to a relationship and marriage. Now I have a nice little kiddo, and this is my daughter, Rory. As was mentioned earlier, it's super fun to take your kids to meetings and to travel with them. This was Rory's first trip to Germany. She was very excited that she had her own badge and got to play on the robot. Everybody talked to her in German because she looks like a little German girl. And so she, is getting to see the world a couple meetings at a time. So I'll conclude maybe a little bit early with some take-home messages, which is that mentorship and sponsorship are all part of the algorithm of success. And the fact that a Jeff Marks and a Jeff Ponsky, and SAGES members, and there are many, many SAGES members like them, will reach out to kind of make themselves part of your success is why the society is great. I think Dr. Peterson and Dr. Tellum have both mentioned their mentors, by name and how they impacted their career, and it's true for me as well. I think you have to recognize when you're being given an opportunity and then take it to completion, and that echoes what Dana said earlier. If you show up and do a good job, or just do the job, there are lots of folks who don't take those first two steps, and you will get noticed by doing those things. Finding projects you love is important because it will never, ever seem like work. I do all sorts of ridiculous stuff with an endoscope, and some of it's in a lab and some of it's in actual humans because we know we did it in the lab. Some of it's device and design and, development and design and testing. It's so much fun. And again, it's a career that I sort of stumbled backwards into. But as it turns out, luck is actually a skill. And it's one that you can learn over the course of time by simply understanding the thing I said earlier, which is you got to recognize when something important or lucky is about to happen. And once you see it a few times, and believe me, I've missed good opportunities. I was supposed to write a paper one time with an Iron Chef, and I totally dropped the ball, and he doesn't answer my emails anymore. And I'm like, oh man, Jeffrey Zakaria, just answer the email and write the paper with me. You will learn the hard way sometimes as well. With that, I will conclude. As everybody else has said earlier, please, reach out. I'm available by email or on Twitter if you want to DM me, and I'm happy to answer any questions that you guys have. Thank you very much.
Just briefly, Eric, I'd like to recognize one of my chief residents, Evan Liggett, is completing military service next year. He's very interested in bariatrics. I'd like to see if Dr. Liggett has any questions. He's PGY5, and I'd like to look at bariatric surgery as part of his military service. Dr. Liggett, can you speak with us?
Yes, sir. Can you hear me?
Yes,
Yep.
we can. Thank you for your service.
Sure. Thanks, Dr. Pauly, and the rest of the panelists here. I don't know if I have any specific questions, but it's definitely a breath of fresh air to hear success stories. And I think I would include myself in probably a lot of us that enter surgical residency with this, I guess, idea or having ideas to kind of want to change how things are done and be innovative. It sounds like SAGES promotes this whole meeting. Sounds like y'all are promoting this, and it's good to hear that becoming a part of the society, you can get in touch with the right people to get stuff done like that. I know starting from the beginning, I've always had ideas about, especially with the endoscope, how to do procedures better, differently, potentially better, I guess. And I've never really known how to go about getting those ideas out there and practicing them. It sounds like, you've been successful in that, and that's very encouraging. Go ahead.
Absolutely. You will find SAGES is extremely supportive of ideas like that. I mean, this is a society that was founded on the fact that most people who, were doing minimally invasive surgery when the society was founded were told that they weren't real surgeons, right? Real surgeons do big open operations, not those little poke hole things. Real surgeons don't use flexible endoscopes. They just cut people open. I mean, these are concepts that are, core to what we do. And if you look at the SAGES logo sitting behind Dr. Davis there's a big flexible endoscope and there's a Hopkins rod lens. And those are the two instruments that are on there, right? So, there are things here that are intrinsic to the nature of the society. So I would encourage you, as somebody who's going to go into bariatrics, to find a bariatric program that does, a lot of flexible endoscopy, because you're right, the future of bariatric surgery is going to heavily revolve around a flexible endoscope. So find those opportunities and jump at them.
Okay, thank you.
Thanks, Evan.
You're welcome.
Well, I think it's time to go on to Dr. Mike Awad as our last speaker, and probably the one that ties us all together the best nationally with his innovation in education. Mike, thank you for speaking.
Brian, thank you very much, and greatly appreciate the opportunity to contribute to the panel today. All the speakers were amazing, and frankly, I learned a ton, and still learning a ton, actually, about career development. So thank you all to the speakers. I also want to thank the attendees for being a part of these webinars. I still remember kind of the very first SAGES courses and things that I went to. And for me, I think that the common theme of my discussion with y'all this afternoon is how transformative SAGES has been to me personally and to my career. And I too have some slides that we'll go through, but I'm happy to kind of take questions in the chat while we're talking or afterwards as well. All right, Dr. Davis, that's showing up okay?
Looks great.
All right, great. I just a little bit about me, as the other panelists have done as well, and because we obviously have been focusing on our careers, and career is a big part of what I do, but also a big part of me is what happens outside the hospital and the wards and so forth. So I'm married. My wife is a gastroenterologist, and we met in college. I've got two kids who are 15 and 13, just starting high school and middle school. So, we try to optimize the times that we do have together outside the hospital and school. We like to travel a lot, as you can see here. I was a little bit about my path as well. I was born in Boston, Massachusetts, to a set of immigrant parents from Egypt who came with $300 in their pocket. And I bring that up just to mention that I really didn't really have a good sense of kind of how to navigate certainly academic environments, and didn't have a lot of initial mentors growing up, but certainly developed some later that were instrumental to my careers. I then moved as a young child to a place called Scranton, Pennsylvania. This is a picture of how it looked at the time. Some of you might know Scranton, though, a little bit better by what it was known for, which is the Office TV show. I don't recall
I
seeing
grew
it.
up. I grew up in Scranton. I had no idea you're from Scranton.
Is that right? Yeah.
Yeah.
Yep, sure did. Yeah, we'll have to compare school teachers. Or, yeah. I don't recall seeing a Dunder Mifflin there, but yeah. And then later moved to Asbury Park, New Jersey. I still try to control my New Jersey accent, but it slips out once in a while. But this is Asbury Park, also perhaps better known for the bus or Bruce Springsteen. Then I went to college, and I also did an MD PhD program at Brown University in Providence, Rhode Island, where I met my now wife, as I mentioned, and then did my general surgery training at Johns Hopkins in Baltimore, Maryland. At Hopkins, I think that's where kind of I first developed some of the mentors that I now still continue to hold very dear to me, who kind of helped me provide some direction. Like Dr. Paula, I wasn't too different that I can't say I really had a distinct plan as to how to get from A to B. If I did have a path, it was very non-linear, so to speak. One of these first interactions was with Julie Freischlag, who was the brand new chair of surgery at the time. She was the first female chairwoman of any major clinical department in the 100+ year history of Johns Hopkins. And when she came, she had been meeting with all of the residents one-on-one to get to meet them. And she met with me and sat down and said, Mike, what are you interested in? I was actually in the lab of a surgical oncologist. Spoiler, I'm not a surgical oncologist, which tells you, I've also changed my mind several times. But she was like, what are you interested in? And I talked about surgical oncology. And then I let slip, and surgical education. And at that time, that's not something we really talked about openly. Like kind of Dr. Paula's story, it was the old saying that if you can't operate, you teach. But I don't know, for whatever reason, I felt comfortable enough opening up, and I just said, yeah, surgical education. And her eyes opened up and she said, oh, really? Well, that's good, because I'm interested in surgical education too. And our residency program director is leaving, and we have an RRC site visit in 9 months. And we have no formal curriculum, no formal evaluation system. Not a single resident has stepped foot in our sim center. And by the way, this new duty hours thing is coming online, and I need you to help kind of figure it out and create a system to track it. So I was like, well, okay, let's go. And, to have the chair's kind of support, not just financially, but also, in spirit, was a tremendous opportunity that allowed me to pursue a lot of those interests at that time. But one of the other folks that I met in the lab was this gentleman, Mark Tagliamini, who was at Johns Hopkins at the time. We didn't have a section of minimally invasive surgery. The chair at that time didn't believe in minimally invasive surgery, thought it was a fad, and that it would pass. But Dr. Tagliamini nonetheless carried the torch. And he's the one who kind of first took me under that wing, I guess saw, that I had interest in similar things, introduced me to SAGES, encouraged me to apply as a candidate member at that time, and had me join a committee which was then known as the Resident Education Committee, or Res Ed. And this was back in 2003. And I'll connect the dots later on that part of the story. But that was my first introduction to SAGES. And oh man, that was, again, I'd say a really transformative time and a transformative event. I remember going to my first meeting and just feeling like, man, this wasn't kind of old, stodgy, folks, and, how fun it was and how inclusive it was. And, it was really told that it was a meritocracy, that it's a society that recognized and rewarded work. And I still very much believe in that to this day. So, I'd pretty much been kind of focused in the Northeast for all my life. I decided to kind of break out and travel to Portland, Oregon for my MIS fellowship with a kind of a pseudo private practice kind of hybrid academic group known as the Oregon Clinic. There I met kind of one of my other key mentors, a gentleman named Lee Swanstrom, who is also one of the past presidents of SAGES, as was Dr. Talamini. I did my fellowship there, for 1 year. It was a very busy fellowship clinically, but also got a lot of advice, SAGES advice, from Dr. Swanstrom, which continues to serve as a mentor for me, even though now he's retired and enjoying kind of the south of France. Much longer hair than is shown in this picture here. So after a year in Portland, Oregon, I basically kind of ended up in the Midwest, where I am now, here in St. Louis, Missouri. Really not thought much about the Midwest, admittedly, prior to coming here. Although when I interviewed for fellowship, I looked strongly at WashU, met a few folks, Mike Brent Matthews, who I remembered fondly, looked for a job, and when I looked for the job, it was at the pit of the 2008 recession. So almost every place had hiring freezes and said, sorry, doors closed. But these folks remembered me from my fellowship interviews, and while I ended up going to Portland, they said, well, come on out, let's talk, and one thing led to another, and here I am, where I've been ever since. So this is a picture of the campus of WashU Medical Center and Barnes Jewish Hospital, where I work now. And my clinical focus is in foregut surgery. I do robotics and some flex and endo, kind of natural orifice, as Dr. Paul talked about, and kind of emerging technologies. But again, my other kind of hat that I wear is in education. And that bug bit very early, for me. And once it bites, it really never lets go. I really liked teaching. I really liked education. That experience I had in residency with Julie Freischlag just showed me how much fun I had being able to just develop curricula, to teach, and to be a part of that. So I didn't know how that would kind of manifest, but I just knew that for my first job, I wanted education to be a part of what I was doing. And so that's kind of one, take-home point that I would say is just kind of, have that conversation with yourself. Identify what your passion or passions are. Identify that priority. And then when you go to look for the first job, make sure that that's recognized and supported. I did look at a few places where they said, yeah, education's good, sounds good, we love education. But, I felt like at WashU at that time, and still today, the chair, who's Tim Eberlein, and the program director at the time, who's Mary Klingensmith, really kind of put the money where their mouth is and, walk the walk. So they gave me a role as an associate program director right out of the gate. I was put in charge of the residency curriculum and skills lab. But I also felt, as Dr. Tellem, described, kind of I felt somewhat lacking in my own skills with regard to education. It's one thing to give a talk or a lecture or run a skills lab, but I really wanted to make sure that these things were effective. How did I know that, this lecture skills lab was making a difference, was moving the needle? So I wanted to be able to study it, and also felt like I needed additional training. And as Dr. Tellem said, it's not just letters after your name. It's really, if it builds your skills or adds to your portfolio, then to pursue that. So I wanted to pursue a master's degree in education, but they were expensive. The tuition is $30,000. And how am I going to fund this? And there's several options or roads that lead to Rome, but I was already connected with SAGES, and this Career Development Award opportunity came about. Also, full disclosure, I applied for this twice. So the first time I applied for it, I did not get it. I think Dr. Talon referenced this as well too, which is, if at first you fail, keep trying. Dr. Peterson mentioned this too. And so I reapplied, and in 2011, I actually did get the Career Development Award. And I'll describe what it's for here in a second. But as part of that, I built into it a Master's of Education, what's called a MHPE, or Master's in Health Professions Education. So this is a master's that specifically focuses on clinicians or educators in a healthcare environment. And it was phenomenal. I chose to do it online. They had an on-site format too. Imagine online teaching. At that time, that was just like so weird. Nowadays, it seems like rote. But anyway, I got an online master's through the University of Illinois at Chicago, which was one of kind of the original ones of these. There's many more now. And if anybody's interested in these programs, I'm happy to chat with you more. But it really kind of gave me that skill set, is how do we study our educational programs? How do we develop curricula so that they're robust and meaningful and make a difference? And it was through the SAGES Career Development Award that made this possible. I'm a part of several societies that are education focused, but it was actually SAGES that gave me that opportunity and made this happen and set the stage for me still today. So this, as part of my Career Development Award through my master's program, I proposed that we would work with SCORE, the Surgical Council on Resident Education, to develop modules for them. Back then, SCORE actually was just a series of outlines. There was no content for SCORE. And as you can imagine, that wasn't found to be very helpful. So SCORE was looking for specialty societies to help them develop content. And so SAGES, it turned out, developed the most content for SCORE and still does today. We developed 57 high-quality modules for SCORE using, with permission, a number of SAGES resources, the top 10 videos, manuals, chapters, and other original content. 17 different institutions co-authored this, and it's still in place today. In the SCORE modules that you see today, a lot of those were developed by SAGES. Like I said, the most of the SCORE modules were made by SAGES members. So it was an awesome opportunity, to do this and contribute. And again, that was through my Career Development Award. This is what it looked like back then. So this is SCORE before it was kind of a little bit in its infancy, perhaps. This is just a list of all the modules. These were all developed by SAGES members, and the pages go down the screen. This is what SCORE looked like back then. We developed kind of the curricula that were broken down by PGY years, again, through SAGES guidance and content. We developed multiple choice questions where there were none before, again, through SAGES. You can see here what they used to look like. I won't go through each of these, but this is a little bit of a flash of the past from SAGES, from SCORE early days. These are content that SAGES contributed to the SCORE modules. This is one of the SAGES top 10 videos that is also originally part of SCORE. So, this really opened the doors for me locally. I've been kind of in various educational roles, here at WashU, from a clerkship director, program director, and associate dean. And I still direct our simulation center, what we call WISE. But as the same as the other esteemed panelists that you heard from today, it also opened the doors up to national opportunities. Now, that resident education committee that I got to be a part of as a sparky young resident, I now have the opportunity to chair. It's was a great honor for me to be able to follow in the footsteps of folks like Brent Matthews and others who chaired that ahead of me. And other roles within SAGES, what's called the Education Council, and also serve on the Board of Governors. But the work in SAGES also opened up opportunities in other societies. That Association for Surgical Education, I'm now on the executive committee and the leadership track there, as well as a number of the other societies that you see here where I have education roles as well too. So kind of the bottom line is I can say without a doubt that the SAGES as a society and specifically the Career Development Award was instrumental in launching my surgical career and my career in surgical education. With that, again, I'm very grateful for the opportunity to present. As with the others, I welcome direct contact, and please don't hesitate to reach out to me directly. Thank you.
Thanks, Mike. I think it's good to go into a little bit of group discussion. I've got one big question for several of the faculty, and then I see Dr. Ahmad has got several of my residents lined up that are very interested in asking further questions. You know, I've really, in recognizing the amount of educators in the room, I mean, I loved your story about Julie Freischlag throwing you under the bus right before the site visit. And just like Eric Hawley talks about taking over after Ted Truss, I know Rebecca Peterson's an associate program director. I've had my own trials and tribulations. I mean, being program director is trial by fire. And the whole educational task is the unsung hero. Can you talk a little bit about that trial by fire? Because I know there's a bigger story behind that kind of challenge, developing a whole curriculum 9 months before a site visit, or running an entire committee when Ted Truss knocks out, or the other challenges we faced. And I know Dr. Peterson's written papers on education during COVID. Things like that are really challenges that people don't talk about much with education. Take a start, Mike.
Yeah, sure, Brian. I think, you know, those experiences, while rarely planned for or predicted, you know, really, like I said, can be life transformative. And, you know, they spur you on either because of your passion or because of the pressure, the time factor, you know, whatever it might be. But it really drives you to kind of excel, to do your best. You know, it obviously does require support. So, you know, if my chair wasn't interested in education, you know, and I said, oh yeah, I want to develop this curriculum and all these assessments and all that, and they weren't interested, you know, that would have fallen on deaf ears and gone nowhere. So I think just like the others said, you know, that perfect storm of those kind of crucibles and kind of the support to help you through it is key.
Eric, would you like to talk about taking over for Ted Truss and the challenges through SAGES?
Yeah, you know, again, this is one of those things when you're kind of thrust into a situation where you are A, not prepared for it, and B, there are some consequences to getting it wrong. You know, I mean, things can go a little bit wrong. I mean, they can go a little bit sideways if you're not lucky, I guess. I think that in that particular case, you know, I obviously had the support of an entire committee and the people above me who, you know, trusted me to do it, and I knew that I could go to them if I had problems or issues. So, you know, again, from a society perspective, SAGES, you know, lets people have some room to run with things, but they're not going to let you fail in a way that's particularly bad as well. So as much as my imposter syndrome kind of kicked in when somebody was like, hey, you're going to be the chair because you've already been the chair anyway, I was still kind of like, I'm not really sure that you guys should do this, but what's the worst that could happen? It's your decision, not mine. So yeah, you know, as Mike said, they're challenging situations, but you kind of find out who you are and what you're made of in those circumstances as well.
Great feedback. I'd like to call on Dr. Peterson. Seattle's in the news every day with all the riots, looting, and wildfires you're experiencing we talked about earlier. And you wrote a great paper about education in the time of COVID. Would you like to talk a little bit about managing crisis with residents?
Yeah, and I don't hear as much news about my own city as you all do. But yeah, it was definitely ground zero. I think the biggest thing during crisis, and step up in leadership, I was very pleased to be where I am. It was a very big effort teamwork wise, and I think communication, it came down to communication. And we're talking about a pandemic and a time of safety and education and patient care and flux. And I think that the thing that got us through was communication and leadership. And the resident that actually wrote that restructuring paper, for basically platooning and organization of 5 different hospitals, is an amazing resident. He actually came up with the restructuring plan. And I think having folks that think outside the box and communication and a lot of support was what got us through. I will say we did get hit, but I think we were prepared to get hit a lot harder. And I can't say enough about teamwork, effort, and really taking the time out. Everyone rose to the occasion. I would say we all weren't working, but we were working 24 hours a day, thinking about it and restructuring. And in the end, we got hit, but we're kind of dressed for the prom, but we really didn't go, thankfully. So it came down to communication and leadership from my department.
Especially from you and your position in leadership too, really did. I'd like to open it up for, I know Dr. Ahmad's on, I know I've got some residents in the wings waiting anxiously with questions.
I just wanted to say thank you for the talk. For Dr. Pauly, Dr. Peterson, Dr. Talem, Dr. Awad. Your talk actually made me realize how blessed we are with the opportunities that we have, and how we tend to not notice them just because they're in our face. I'm a foreign graduate, and I come from Pakistan, which is a country with fewer resources, and I actually belong to a family of surgeons. So for my father, he always said, yeah, pick at any opportunity that you get. And he was that kind of person. But for me, it became more of I've started taking things for granted since I've been here. And I realized with Dr. Talem's talk that you had a set of struggles to go through here. If I need a database, I have someone to look up to, and somebody's going to give me some instruction or some guidance as to where I can find a good database to do things. So I think that, this talk itself has opened a lot of windows for me at this point. I do have Dr. Harper here with me. She's interested in MIS, and she actually has a question, and we've been talking about this for a bit. Dr. Harper, would you like to go?
Yeah, I guess I just had a question, since a lot of you guys are educators and talking about MIS education. Sorry.
Can you come closer to the camera?
Yeah. So since you guys are talking about MIS education, I was curious about where you guys think MIS fellowships are going to go. Do you think that they are going to be phased out because residents are already getting that training during residency? Or do you think that they're going to continue to develop and change?
Great question for the panel.
That's a great question, and also, defer to the others for their thoughts. Dr. Paula, as you know, is in the Fellowship Council board and has some interesting perspectives. I don't think fellowships will go away. I do think there is still a need for specialized training. Just full disclosure, I did recently write the FORGUT Fellowship, so I'm perhaps a little bit biased, but I think there is pretty clear evidence that in certain areas, specialized training really does impact clinical outcomes and patient care. Having said that, I think what we will see, which is in evolution right now, is how residencies transform to incorporate that specialized training. Do we still need, 5 years of general surgery for everybody? the American Board of Surgery does offer this flexibility option where you can spend 12 months in your last 3 years in one focused area. And I do think those are segues to kind of help us understand if that allows one to perhaps shorten your general surgery residency, and, kind of do your fellowship, kind of almost at the tail end of your residency or in residency. That's just my opinion, but that's where I think things might be going.
I think that one of the things that we've seen over the course of time is just just as the amount and types of minimally invasive surgery have changed in residency, the fellowships have changed as well, right? When these fellowships first started, it was like the wild, wild west, Somebody would hang a sign up and said they were teaching MIS, and you would go, and there was no match process, and you learned what you learned and you didn't, and then you learn the rest on your own. And now we have fellowships that are heavily regulated, and we know the educational content of all of them, and we have literally just changed the definition of what a minimally invasive fellowship is, including the case numbers that are required and the types of procedures that you're going to do. And so I don't think fellowships will go away, but I do think that there will be a constant evolution of what is the content, what is resident content versus what is fellow content. A lot of the things that I do, like with a flexible endoscope, there's no way that a resident is going to learn it in their time frame of residency in the foreseeable future. But as residents do more and more, I've got chief residents who show up with some good endoscopic skills, and this instance comes to mind. One of my chief residents was shoving an endoluminal vac down to fix a mid-thoracic esophageal leak, and she was putting a vac around the aorta. And I thought to myself, it's a Friday afternoon, and I got a chief resident putting a vac dressing on the aorta, and I don't even have my hands on the endoscope. We're doing something right here. So things will change, but probably not go away.
I actually thought a lot about this question because we just applied at Michigan to start a fellowship program. And I think it just made us a little introspective, thinking, well, what actually are we starting? How is this going to complement the current residency focus? How is this going to be different? How's it going to change? How can we offer people who are already coming out of surgery tremendously trained? I think any chief resident graduating surgical residency is probably so well ahead in MIS than anybody was 8, even 10 years ago as things were really starting to take off. And I think what we're seeing now is sort of further specializations of these fellowships. To Eric's point, there's not sort of this wide MIS fellowship. There's more like bariatrics fellowship, where you're getting very immersed, not just in the surgery, but in the comprehensive care of obesity, from nutrition to psych to the surgery to the follow-up and what that looks like. You're seeing abdominal wall core fellowships, again, a very specific skill set. Flex endo fellowships, very specific to that. And so I think what you'll see is just a further narrowing of the scope with a higher degree of sort of specification and depth, to be quite honest. And I think that means that that's a success. I think, to Eric's point about the Friday afternoon vac, I think when I have my chief residents taking my juniors through sleeves, I'm like, this is awesome. This wouldn't have happened, 8 years ago. So I think it's really just a testament to the success and to the takeover, of kind of MIS therapy outside of feel a bit more as a skill set that's an expectation rather than further training. But I do think some things will require always further specialization, and fellowships will exist for that.
I think another question that's great, we've got Dr. Tilem on, who really took a very innovative path with the Masters in Public Health. Do you think, and I know other people have done research fellowships, do you think residents should start considering taking that year off to do public health research and get more involved in these fields as an alternative to doing a basic science research lab? I know that Dr. Peterson spent a year with the thoracic oncology lab, and it seemed like half the papers were there from Duke from that lab, which is amazing productivity and amazing mentors. At the alternate time, you've really stumbled onto an alternate pathway that has just blown up a huge career in quality outcomes research.
What a contentious topic, and some fun. I think people should do what they're passionate about. I think there's a lot of expectations placed on our residents that if they don't do research, somehow they're going to be lesser surgeons and they're not going to go off and to have these phenomenal careers. People should do research because they love doing research, and they should do the type of research that makes them happy and that makes them go forward. And we get into this sort of all the time. You know, we have our residents kind of take 2 years out in the lab, and every once in a while we get someone that says, well, what if I don't want to do research as a career? And it's almost kind of this like shame that somebody has that they're not going to do this. And I really think that whatever you do should have passion and meaning and should intersect with your career. I love outcomes research. I think why I said that was because it anchors on clinical problems that I see when I'm in my office and I see something, I want to fix it, not just on that micro level, but on the macro level. I have phenomenal respect for basic scientists. I don't know how they do what they do, but I also think that if people want to pursue a career in global surgery or education, it's equally as valuable. I also think being a private practice community surgeon is equally valuable, and that we shouldn't pigeonhole people into our sort of expectations. Same way that, you know, if somebody says they want to be a breast surgeon or versus a pancreas surgeon, somehow that's not real surgery. And I think we have to move out of shaming people for what their desires are. So I am all for whatever that person wants and supporting them in any way we can.
Yeah. Sorry.
No, it's great. It's great. No, I do love the contrast, Dr. Peterson, because you really do have a phenomenal amount of work out of Duke in those years you took in the lab in basic science, thoracic oncology. How does that shape your practice now when you're talking about outcomes for paraesophageal hernias and hiatal hernias? So obviously there's a huge amount of crossover.
No, I basically went to Duke to do thoracic surgery, along with all of my colleagues, all 6 of us, which the majority did. But, you know, I think, I don't think the ladder against the wrong career path or specialty is necessarily takes away from where you end up, because I learned a lot. I learned that I did still love the kind of esophagus and those operations, but from the abdominal approach instead of thoracic approach. I think doing translational research for me taught me to interact with basic scientists, the processes of writing grants, presenting. I think that I don't regret those 2 years of my life that I spent in the lab. I also got married and, you know, got a dog, and, you know, but it, you know, all that is important. I think that you don't really, in my opinion, I also spent 2 years getting a master's degree in epidemiology as well. And so, you know, in the end, you're kind of old when you finish, but I wouldn't change anything necessarily. I just think that I think the themes of this webinar is really, I like the word intentionality that Dr. Tillum is really throwing out there, and passion. You know, I think we all just I loved being where I was at the time, and I think that sometimes you just don't know exactly what you're going to do. And I don't regret a second for not doing thoracic surgery. I'll tell you that 1 month before applications were due. But I have gained a lot of research experience and benefited greatly from those years. And still in contact with all of those folks. And there's crossover between what I eventually ended up doing and what my training was in the past. So sometimes you just don't know, and it's better to change your mind. You know, I guess that's what I try. If you go into a basic science lab, it's not a waste of time if you're not a basic scientist, but you know, you still are learning.
My current fellow actually did 2 years of surgical oncology research. And I mean, she had a ton of publications and she had some grants, and she was clearly like very good at that stuff. And then she realized that she doesn't like taking care of cancer patients because they die a lot. And she liked MIS a lot better. And when she came and interviewed, she, you know, at times was almost apologetic that she had changed her mind. And I mean, I looked at her square in the face and I said, I don't really care what you did research in. You've got a CV that you could be sitting here for any fellowship that you want. The fact that you have sat down and thought about your career and what I want to do and what makes me happy and what am I going to be successful at, and realized it's not the thing that I just invested 2 years in, shows me that you're mature and capable of making good decisions, and you're probably going to do good MIS research as well. So it says a lot when people change their mind and then, come to a rational decision about why they want to do some part of their career that's very different than what they thought initially.
Dr. Peterson, you made me cringe when you said old. We all were joking earlier, we all have elementary school age children. You've got children, Dr. Lim has children, Dr. Awad, Eric showed great pictures of his kids. We're all living that dream of having both. And I think it's important to emphasize how exceptional people's careers can be by really networking and using those opportunities through these societies to balance both. Would you like to talk a little bit about that, Dr. Taleb and Dr. Peterson?
About being old with kids, I could talk about that forever.
Not old, we're not old yet.
I could talk about being old with young kids for an hour. We don't have that kind of time on this webinar. I'm sorry, which part of that did you want me to talk on?
I think it shows great balance. It shows great balance. I've got a 7-year-old. You've got discussion, a couple of your kids breaking in the room. It's great. And to have all that together with your CV and connections and networking, and then be doing all that at the same time is remarkable.
I appreciate that. I always joke, like every morning we wake up and I just try to get one foot in front of the other, like wrangle some child and get in. It's not easy. I mean, there's certain sacrifices that you have to make. I'm sort of very open about that, particularly for women, issues with having kids when you get older, issues with when do you have kids, how does that impact your career, whether or not people think it impacts your career and what your personal perception of what things do to your career. And what I always say is like, you can have everything, but you can't have everything kind of all at once. I would never call my life balance. I would call it like some bizarre, weird world of like integration where you just kind of make the best decisions you can. I'm not the best mom every day of my life. I'm not the best researcher every day of my life. I am the best surgeon every day of my life because that's patient care. And that's one area you can't do. So you figure out what workflow kind of works for you and just try to do your best every day and hope you make enough money to afford therapy for your children sometime down the line for everything you do. But I'm very blessed and fortunate. I have a wonderful 5-year-old, a wonderful 2-year-old. I have a great spouse who's extraordinarily supportive, and I couldn't do what I do without him. And I think if there's one piece of advice, choose who you spend your life with well, because that person will make and break anything that you can do. And yeah, I don't know about balance, but we try to do it every day.
Yeah, so my twins, boys, when I was a junior faculty, I got pregnant during my second year with the twins, complicated, Pellegrini's fellow, Brown-Schlager's fellow. It was difficult. And I got hired on faculty the day after I finished my fellowship. I started the next day. And it was a rough 2 years. It was really, really fun, really, really crazy. I can't really remember anything, but you make it work. It's so dynamic, and things that I stressed about then, I don't stress about now, where, sometimes I don't know if I have a nanny, but just like, if they're going to come, like if they're going to be around, my kids are online, so I become a lot more flexible. And I think flexibility is my main recommendation. Try to be more flexible. I tended to be very rigid and thought I had to have someone, when my husband's, who's an interventional cardiologist, and I'm with the twins and we have a nanny working, does she need to really work 60 hours, or can we kind of like, really fly by the seat of our pants a little bit? And I think flying by your seat of pants a little bit more and being less rigid is actually how I've become more sane over the years. Yeah, that's all I have to say. Yeah, and don't get too many animals when you have young kids. This is a disaster with my dogs and a cat and twins, and yeah, so one thing at a time.
Great feedback. Any more feedback from my residents? Any questions from Dr. Harper or Ahmad? We're still waiting for more people to ask questions.
It's just refreshing to hear more women in surgery per se say that anything is possible, and it's nice to hear that, you know, you may not always have the perfect balance, but you just learn to sort of deal with things a day at a time. Yeah, I completely agree, Dr. Tallon, with your opinion of choose who you spend the rest of your life with wisely, because that's super important. Yeah, I don't have any other questions right now, but I would definitely say that this has been a very, very interesting talk. And, you know, you just make me realize that anything's possible. You can take at any opportunity that comes your way. I mean, you know, I never knew about this liver fist. I didn't know there was an actual publication, Dr. Pauly, on this liver fist. So now I'm going to go read up on your paper. That's one of the few things that I'm going to do. I've seen people do it, and I thought that it was just one of the things that people just did, you know? So definitely, you know, I've learned quite a few things today. I really appreciate the time that everybody took out. I guess the only other thing, and I was talking to Dr. Harper, we were actually talking about this, you know, future of MIS fellowships. And I've only seen one kind of MIS fellowship. I was at Southwestern for a year. So, you know, that was mostly a hernia fellowship more than anything else, and not so much endoscopic surgery. Do you think that as time goes by, MIS fellowship is going to be integrating endoscopic and like bariatrics the way it is right now, and hernia and everything? I didn't see a lot of endoscopic surgery. I mean, I see it now as a resident here, because Dr. Davis does a few minimally invasive or endoscopic surgeries. But do you think that, you know, or do you think that it's just going to become more divided, and, you know, you will have to choose between one or the other?
Well, the new definition of MIS fellowships actually requires flexible endoscopy, foregut surgery, hernia surgery. You know, there's case volume requirements for all of those things. Bariatric fellowships will have some requirements for endoscopy as well. And we're working to kind of redefine what flexible endoscopy is, so that programs that do a lot of flexible endoscopy can highlight, you know, that they are flexible endoscopy, you know, that they teach additional things beyond the bare minimum. So again, these things will all continue to change. I mean, as a flexible endoscopist, I say all the time that flexible endoscopy is the future of surgery, but it's been the future of surgery since the thing was invented. I mean, all the things that you would have done with a, you know, as a surgeon in the 1980s are now done on a flexible endoscope, right? GI bleeding and taking out colons because there were polyps that you couldn't take out. I mean, we address these things with non-invasive techniques. So it'll continue to be a bigger part of what we do, and it'll change over the course of time, but there'll always be a need for, you know, the surgeries that happen in these fellowships as well. But learning them in a complementary fashion means that when somebody needs something, you can offer them both, right? I'm not just a bariatric surgeon, I'm a bariatric endoscopist. And I don't just offer people endoluminal sleeves because I'm a GI provider. I can look at a patient and say, for you, a surgery, and for you, an endoscopy. So I think that for me, that's the ultimate goal, is that, you know, my trainees can use all of those tools in their toolkit and bring the right one to the right patient at the right time.
And I think given the way things are going at this point, and the patient population that we usually see, and the number of comorbidities that they have, I think that I'm actually really excited to see how minimally invasive surgery is going to progress, because there's so many things that, you know, we talk about every single time we're talking about minimally invasive surgery, with improved outcomes, less, you know, hospital stay, increased like mortality or improved mortality or morbidity. So I'm actually really excited, and you know, you're opening up a new, a complete, because my concept of minimally invasive fellowship was just MIS bariatrics. And so it's really exciting to hear that there is endoscopic surgeries, and, you know, that would be the expectation as well. I think I've made the right choice. That's what I would say.
Heck yeah.
We're lucky to have you, Dr. Ahmad. I'd like to kind of start to wrap things up by saying to everybody that's attended, please fill out the SurveyMonkey survey attached for SAGES so we get accurate feedback about how everybody's interacted with this format. It's our first in the Zoom series. We're running it independently, and we're committed to running it independently through Zoom with our staff. Thanks so much for Ed Rosado Vanessa Chung, and Vera Ewell from the SAGES staff for helping with all the technical difficulties. Anybody like to say any final closing remarks from Mike A1? I think it's been a very great success right now, technically, for the Resident Fellow Training Committee. I know everybody on the panel are members. Any final comments from the group?
Brian, thank you for your leadership of these resident webinars. Some of you may or may not know, but Dr. Davis is specifically responsible for administering these webinars, which he's done admirably for many years and has shepherded us through this new phase of Zoom. Brian, thank you so much for your leadership in carrying on this important torch for our society and our trainees.
It's a great recruitment tool. I'd like everybody to consider joining as candidate members, and I'll sponsor all my residents myself with fees.